Very full program today, so I'd like to get started as soon as we can. Welcome to the March meeting of Manatee Tiger Bay. I'd like to start off with a pledge of allegiance to the flag, please. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you. We have 3 panel members today who will address you on the variations in the delivery of physician services in Manatee County. I am not going to give lengthy introductions to any of the panel members. Their curriculum vitae are on your table, and they're too long and would take up most of the hour. Scott Clulow is with Pinnacle Medical Group, who will be addressing you. He is also Vice President of the Manatee Medical Society. John Kenneth Lurie is the Heart Attack Prevention Center and will be speaking to us particularly about concierge medicine, which is a new concept for most of us, I think. And then finally, Mickey Prochet, the President and Chief Executive Officer of the Manatee County Rural Health Services, Inc., will address us as far as the mission and the services provided by rural health. As we started at our last meeting, we would ask, if you would like to ask a question, to write it down. There are pencils and paper on your tables. And then I will present the questions or read the questions, and the person who is to whom the question is directed will then respond. Again, only members or friends of Tiger Bay are permitted to ask questions. We would ask that you hold to that. If we do have any time after the written questions and someone would like to do a follow-up or have an additional question to come to the microphone, that will be fine. But again, I think we're probably going to be somewhat pressed for time because of the 3 panel members and the questions that I expect. With that, I'm going to ask Dr. Clulow to begin by making his presentation.
This one right here? Backwards. Good afternoon, everyone. Thank you for coming out today. You'll have to bear with me. I'm a little bit under the weather. If anyone knows a good doctor, they can certainly give me their references for later. My daughter's sick, and so now, of course, I'm sick. But I'll try and get through this without squeaking too much or coughing. If anyone doesn't know me, I'm Dr. Scott Clulow. I moved to Manatee County in 2002, starting to work with Manatee Family Physicians, which was a Pinnacle or a division of family practice with Pinnacle Medical Group, which has just recently been acquired by Hospital Corporation of America. We expect no changes in healthcare delivery, although there may be some nuances with that change. I'm also past president of Manatee County Medical Society and again, current vice president. I've circulated on the board since 2004 and also serve as co-chairman with Manatee County We Care and also serve on the board of directors of Pinnacle Medical Group. And I'm going to start with, I was asked to talk about some of the healthcare delivery systems in Manatee County. There are a lot of issues that are on the table. Most of you are probably aware of them if you're here today to hear about some of those issues and how we're going to address them. I just wanted to talk about some overarching themes. And can anyone hear me okay? While there will be market fads, some current trends are the future reality in health delivery. Some of the issues we're going to be having are access to care. But before we get to that point, I just wanted some statistics. 46 million people in America are without health insurance. Healthcare spending is predicted to be nearly $2.8 trillion, which is almost 20% of the GDP. In Manatee County alone, we have almost 30% of our population is either uninsured or underinsured. Manatee County also has the highest proportion of elderly citizens in the United States. Also, when we're talking about all institutions are going to be required in the future to build for the success of healthcare delivery. What could that be? That can look like not just traditional one-on-one face-to-face interaction with the physician. We're talking about worksite clinics, shared medical appointments, wellness clinics, and such. IT, or information technology, will be key to future success in health delivery, but it must be affordable. That is one of the biggest factors that's for physicians and hospitals across the country, is the cost factor, because it's not just the cost of setting up the information technology, but integrating it. Okay, I'm missing a slide, but that's okay. The next slide was supposed to be current environmental challenges. We're talking about the problems that plague the current health system. As providers, and not just providers, but physicians also are employers, and we're also burdened with the same problems that other businesses are experiencing. That includes rising costs, increasing demand, decreasing workforce, price pressures, patient safety expectations, and regulatory requirements. If you asked a physician 30 years ago about regulatory requirements, he would tell you he'd be spending 80% of his time with a patient and 20% of his time on paperwork. Unfortunately, you ask that same question to physicians now, you'll get probably the reverse: 20% time with patients and 80% work or paperwork. Excuse me. As you can see, preparing for the future, clinical care is the key. We have to lay down the foundation, not just setting up IT, but we want to have electronic patient data with secure access and remote access, which is going to be important in getting people in to see physicians. You want to make it wireless, have options of mobile devices, and being able to integrate those devices. The next stage after that for clinical care will be not just collecting that data, but being able to capture it, report it, and then integrate it. And when we say integrate it, we want clinical applications. In some of the slides I'm going to be bringing up, we have to remember that if you're not familiar with the terminology, pay for performance, they're going to be looking at reimbursement for quality data. Part of that quality data can be implemented into clinical applications, which I'll explain further in detail. Stage 3, we want to prepare for the future. Patient portals, patient health records. Patients are already trying to form their own patient health care records. They did a survey a couple years ago. You're talking over 70% of people would like to have a patient health care record. If you look at statistics, it's less than 6% have actually created one. We also want to be looking at adverse event surveillance, medical device integration, health information exchanges, which is the HIE, which we'll get into in a second, which we've been successfully starting here in the county. Remote consultations and important patient self-management. There are not enough providers to provide care for everyone in the county. So if you can get patient self-management involved, we get the patient involved, and patient being proactive, you're going to get better outcomes data. No, they just reversed my slides. We'll skip that one. We went over that one. Now, when we're looking at the future of healthcare, I like to call it the 4 truths. Truth 1, the expectation that care will be as safe as possible is not going away, which I'll get to in a sec. Truth 2, more patients, fewer providers, plus cost pressures are going to force healthcare organizations to become more efficient. We have to be efficient. Truth 3, cost and quality transparency will be demanded by payers and consumers alike. And truth 4, reimbursement, unfortunately, is going to create a 3-tier care delivery system. Safe care. What does that mean? Safety and reduction in medical errors is going to be key. If we're going to provide health care efficiently and safely. Improvements in health care quality and safety can yield up to $400 billion in savings. I mean, that's a lot of money right there. And IT is going to be important in getting that to fruition. Also, if nobody knows the statistics, and if you go online, you can find different statistics, but deadly medical or preventable patient injuries resulting from medical mistakes cost the economy over $20 billion a year. And that may be as simple as illegible handwriting on a prescription, or in a hospital, again, illegible prescription writing in the hospital. Those are some things that are being worked on. For example, in the hospital setting, and even on prescriptions, we try and get away from example when we write a prescription that says you're going to take a pill every day. It's not written out every day, it's written out QD. And a lot of patients, when they get written out, sometimes will be written, and the physician or the pharmacist will think QID, and they end up getting it 4 times a day. And so we get mistakes like that happen. Those are preventable injuries. Public reporting is going to increase. Both patients and providers will expect data to be readily shared across settings and be available at the point of care, meaning you should be able to have that when you have that, click on that mouse and the patient's file comes up. If you're using electronic medical records, you should be able to get all this information at one time. Not have to call up and get records, not call up to get EKG, not call up to get an X-ray report. It should be there, and of course labs as well. All there to be viewed all at one time. Through judicious use of clinical decision support, providers will be prompted to do the right thing and thus prevented from making mistakes. Again, using IT to put in quality measures into your systems will allow you to help prevent mistakes, which I'm going to clarify that in a sec. And that's going to bring me into electronic medical records. Everyone thinks that electronic medical records, which is going to have a paperless chart. When we talk about EMR, we have to think about HIEs. The true value of EMRs comes from clinical data that can be shared by providers across the community. Therefore, healthcare organizations are going to have to invest resources in efforts that create a health information exchange among partners in the community. And that is very important. We've already started to do that with the Gulf Coast HIE that was spearheaded by Dr. Phil Talley, the Manatee County Medical Society, and so forth. But the biggest barrier still is cost. You do not have to have, and people have the misconception, excuse me, I apologize, that you do not have to have an EMR in place in order to be involved in the HIE, in the Health Information Exchange. You do not have to. You can still share information and not have electronic medical records in your office. But 40% of office-based physicians that are using EMR, only 6% have functional systems. What does that mean? Well, you can have an EMR, it's nice, I have less paper, because you're still gonna have some paper with EMR. I can get my data off on a computer and pull it up. But are you able to use and interface that information? And not only 6% of people with physicians who have EMR can do that. And when I say utilize it on functionality, we're talking about systems. When I talk back about clinical decision making, you can actually get software that integrates the quality core measures for a particular disease. And all that information is coordinated into the patient's chart, and it will actually remind you of something that you may need to do. For example, in diabetics, the certain core measures for diabetics are a hemoglobin A1C, which is less than, currently the core measure is less than 7. You want to make sure that they're screening for proteinuria, or protein in your urine. You want to make sure that their systolic blood pressure is below a certain level and their diastolic blood pressure is below a certain level. You also want to make sure they have an eye exam and a foot exam. Those are certain criteria under diabetics that you want to follow, and those are core measures that are actually being measured right now that we do in our office. But you can have software that will come up and pop up and say the patient hasn't had hemoglobin A1C in so many months. The patient's hemoglobin A1C is greater than 7. What are we going to do about it? They haven't had a urine microalbumin screen. They have their systolic blood pressure is over 140. Things that you can do right then and there, treat the patient, because that data that is used has already been demonstrated that if you achieve those goals, you're going to decrease the complications of the disease, which is increased risk of heart attack, stroke, circulation issues with wounds of the feet, and so forth. So that's what I mean by functionality. Also using e-prescribing. If a lot of people are using e-prescribing without having an EMR, but you can function or integrate those together. And then what will happen is when the patient's already up for a prescription refill, it'll ask you, you press the button, send it, they send the prescription. You don't have to wait and use additional resources in your office to go and call or go and fax the prescription to the pharmacy and then wait for the pharmacy to respond. Everything can be done electronically, which the electronic prescription is great because it'll reduce medication error. I've just been told I have 2 minutes, so I better put this through. You can talk forever. The bottom line is organizations need to consistently deliver safe, high-quality care and know as much about the patient as possible at the point of care, and IT is going to be integral. Truth 2, efficiency. Delivery organizations will need to find new ways of delivering care. Now, in Manatee County, we have an issue. We have, well, a number of issues. One is we have an increasing aging population of our physicians, and we have a decreased number of younger physicians coming into Manatee County, and therefore presenting a growing gap in the county's physician resource pool, access to care. What are we going to do about it? And we can address that. I'll get to that in a sec. So in order for a limited amount of physicians, we can do a couple changes in our delivery. We can use email, Skype, Facebook. Some physicians are already using this. And you can use that to respond to clinical questions, requests for prescriptions, communicating lab results, all stuff that will free up your own staff to get done quicker and more efficiently for the patient and reduce medication error and adherence. Tools that enable quality care to be provided in less time will be premium. Example, we have already available, I don't know if anyone's using them, but we have what's called smart pill bottles. They send messages to the pharmacist and the physician that tell them when the patient has taken their medication and if they've taken their medication. That will help with medication adherence. You can also get bedside monitors that send pacemaker data to websites that are accessible by physicians. You can get bedside scanners that record vitals that send information right to the doctor's office. Providers will need to find ways to enable less skilled workers to safely perform tasks. Organizations will hire hospitalists to integrate consistency into the system. With fewer clinicians, patients themselves will actually become the provider in more situations. Example, with new technologies, we have self-monitoring, which makes it more effective to monitor disease states. Example, digital glucometers to monitor diabetics, electronic scales to monitor your congestive heart failure patients, digital spirometers to monitor your asthma patients. You have now home clinical or home Coumadin meters to help patients monitor their Coumadin levels, and those can all be connected to your cell phone and information transmitted to the physician's office or whoever's going to be monitoring it. Bottom line is, to be successful, provider organizations will need to be more efficient, keep saying that word, as well as align data and empower patients. That is the most important thing, with the information and tools they need to manage their care. Cost and quality. Pay for performance is real, and it's permanent, and it's going to happen. We already know it's already set to take place. It's voluntary now. It will become mandatory, and Medicare is going to be having a national adoption of that, and that's how we're going to get paid. Quality measures will be increasing, and the results will be public. Reputation for quality will not be enough. Some payers and states have begun transparency initiatives already. I mean, you can go on and look at hospital data and physician data and find out what their quality measures are. So it can be measured. Bottom line is provider organizations are going to need to deliver high-quality, low-cost care, capture results, and use them to improve. And IT is going to help with that merger. Truth for multi-tier. Unfortunately, changes in insurance companies are going to create 3 tiers. We're going to have tier 1, which is the patients who have traditional insurance, but they can pay above and beyond what they already pay. You have tier 2, the discerning concern, which with some insurances, but they'll be able to pay for additional services on top of that. And then tier 3, which is the emergency only, those who cannot pay or have little or no coverage. And we know, as I mentioned, in this county, we have almost 30% of people are uninsured or underinsured. And I'm asked to wrap it up, so I'm going to just go through this. You have the slide. And I'm just going to mention it just to wrap this up. The next generation health delivery. Imagine a health system that we have a healthier workforce. That your ability to demonstrate high quality gives you an edge at the negotiating table with insurers. Patients spend more time receiving care than waiting in waiting rooms. You offer patients multiple ways to access information and support, enabling them to be part of their care. Your providers can access the information they need at the point of decision making, and patients are empowered to participate in their care and receive care at home. We recently just formed in this county a Manatee County Healthcare Alliance, which is chaired by Jonathan Fleece. I'm going to encourage anyone who is interested. We are always looking for people to give their input, so please become a member or add some input. We'd love it, because there are a lot of issues that we need to address in Manatee County that are unique to Manatee County as well, and I think that alliance will be a start, along with the help of the initiation of the Gulf Coast HIE, or Health Information Exchange. Thank you very much.
Thank you, Dr. Clulo. Dr. Lurie, would you?
Thank you for having me. I thought today, instead of making you watch a PowerPoint, I'd try to introduce a concept to you. My name is Dr. John Lurie. I moved to Bradenton in 1995. I have board certifications in internal medicine, general cardiology, interventional cardiology, which means I unblock blockages, and nuclear cardiology. I have noticed a huge change in the healthcare system over the last 10 years, and certainly over the last 5 years. I think everyone in here is a patient, including myself, and I'm sure everyone can agree that we have found dissatisfaction somewhere in the system. I think it's become a dysfunctional system in many ways, and that really has led me to look for a better way to deliver care. What am I talking about? Well, today, in order for most practices to survive financially, and believe it or not, although the U.S. is spending more every year on health care, the price of health care is going down. The cost is going up. So the price of a CAT scan, the price of a hip replacement, the price of a chest x-ray is actually going down. That's set by the government and mostly followed by insurance carriers. The cost is going up. So how's that possible? Well, more people are demanding more services, and as reimbursement goes down for hospitals and clinics and imaging centers and doctors, and unfortunately the truth is that there is a business behind each one of those practices that has forced physicians to practice defensive medicine, which means make sure I don't make a mistake because I'm still on the hook for a potential lawsuit that may be huge, and you have to cover your rear. So more and more CAT scans are being ordered that may not be necessary, more and more blood tests, et cetera. So that overutilization is where the cost is coming in. The price is actually going down. So as physicians have to survive their own practices, what's the solution? The solution is I have to see more patients today and tomorrow and next week. Well, there are only a certain number of minutes in a day, and most practices are only open a certain number of hours in a day. So that forces smaller and smaller appointment slots, shorter amount of minutes with your physician when you see them. Who has not experienced that? Or you may no longer see your doctor. I see a nurse practitioner. I see a physician assistant. Those physician extenders are really now becoming mandatory to keep the practice alive financially so that more people can come through the door so you can keep your practice open. Do you think that delivers better care? I don't. So 10 minutes, 8 minutes with a patient, 1 to 2 or even 3 times a year is certainly not enough to discover all the issues that need to be discovered and treated. So I've been asked to speak about private practice or concierge model medicine, which I changed to in January. So I know both ends of it. I've been in the system the traditional way since I started medicine. In about 1.5 years, I decided that the patient frustration was obvious, the physician frustration is obvious, and if you go to any medical lounge at the hospitals, people aren't talking about the stock market, they're not talking about their vacation plans, they're disgruntled, they're upset, they're complaining. It's universal. So there's clearly dissatisfaction from the physician's end, there's clearly dissatisfaction from the patient end, and there's a better way. And the issue is delivering the care that you want to deliver as a physician and receiving that kind of attention that you expect as a patient. So my focus is really on meeting that expectation for patients and also working with a background in cardiovascular disease to prevent the #1 threat to all of us. If you look at statistics today in the United States, what's the #1 risk to your life today? It's heart attack. 1 in 3 Americans will die of a heart attack. So that's 1/3 of this room, 1/3 of every table is going to die of cardiovascular disease. So we see a lot of good press on a lot of health issues. For example, women's health issues. Breast cancer comes to mind. Gets a lot of attention, and it should. About 40,000 women a year die of breast cancer. Guess how many women die a year of heart attacks and cardiovascular disease? 400,000. 400,000. So your #1 risk is heart attack, not breast cancer. So how do we screen for breast cancer? Anybody? Mammogram. So what are we looking for? Early cancer so we can get it out and cure you so you don't have widespread disease. Same thing for colon cancer. We have colon cancer screening awareness. If you don't look, you don't see it. It's one of those cancers that can go really hidden for many years until it's too late and spread. How do we screen for cardiovascular disease? We don't. That's right. We measure your risk factors. We measure your blood pressure. We measure your cholesterol. We measure your fasting blood sugar. We ask you about family history, and we add those things up. We might look at your HDL, the good cholesterol, and the LDL, the bad cholesterol, and we put a point score to it called the Framingham Risk Score. And then we say, well, you're at low risk or you're at high risk. But we're looking at risk scores. We're not actually looking for the process, which is the disease. So that's really what I'm focusing on in this practice. If you focus on looking for the disease, you can find the disease in the earlier or moderate developmental stages and arrest the disease process in its tracks and actually reverse it. So if the #1 risk to our lives is heart disease, why aren't we doing a better job in looking for it? It's also a huge cost. Dr. Clulo talked about some cost of medicine. If you look at just one statistic, stroke cost, for example, it's about $180 billion a year to take care of stroke patients. 65% of those dollars go to nursing homes. That's too late. We can show almost the same statistic for things like diabetes. Who gets amputations? Diabetics. Who gets heart attacks and strokes? 75% are diabetics. So our number one risk, which is cardiovascular disease, is being driven by a huge epidemic, which is diabetes. How good a job are we doing on diabetes? Well, if you go to the National Heart, Lung, and Blood Institute, you can look up the data. It's public data. Of all the diabetics in the United States, 12% have the diagnosis made and are receiving proper treatment. 12%. About 65% are receiving no treatment. Either they don't have the diagnosis made, or they have the diagnosis and they're not getting treated. So if only 12% are getting proper treatment, is it a mystery now why we have a high rate of stroke and heart attack and we are not really seeing a big dent in that rate? It's not surprising. So we talk about prevention, and it's a great concept, and it's very effective if it's applied, but we do a perfectly horrible job of actually delivering preventative care. If you could prevent diabetes, and it's by and large preventable, by the way, type 2 diabetes, which is 80 to 90% of what we see, is preventable. So you say, well, that's great, why aren't we doing it? Well, what's the definition of diabetes? Definition of diabetes in the United States is a fasting sugar of 126 or higher. It has to be over 125. So what happens at that blood sugar? So that means that when your pancreas is resting, quiet, hasn't eaten for 12 hours, it can't function. You can't make enough insulin to keep your blood sugar normal at rest. Studies have shown, and this is well published, that by the time you reach the diagnosis of diabetes, you have 10% of the cells left that make insulin in your pancreas, the beta cells, 10%. So what happened at 30%? You're not called a diabetic. What happened at 50% loss? You're not a diabetic. You're pre-diabetic. What do we do with pre-diabetics? Nothing. We say, yeah, your sugar's 102, it's a little high. We'll watch it next year. So we watch it and we watch it. And so decades of opportunity to get in the way of the number one threat to our life goes untreated until 90% of the problem is already past. So if that was a house on fire, I use this analogy in one of my talks, and we waited till 90% of the wood was burnt before we pull the fire alarm, how effective would that fireman be? Totally ineffective. So my point in all this is that we need to learn to walk before we can run. And we're not doing a very good job in walking, which means we can't even do a good job treating the diseases that we're treating. We have American Heart Association guidelines called Get With the Guidelines, and every fall we have a Get With the Guidelines media push, which means even using the national guidelines that say your blood pressure should be a certain number, your cholesterol should be a certain number, your weight should be a certain number, your blood sugar should be a certain number. We are not achieving those guidelines. If you look at how good those guidelines are, they're horrible. Horrible. What's the guideline? I'll give you one example. LDL cholesterol. Everybody's heard of LDL cholesterol probably. That's the stuff you're supposed to be afraid of. Plaque-causing stuff. It's one of them. If you're said to be the highest risk person based on these point scoring tools that we use, the national recommendation is that we get your LDL down to 100. If you're the highest risk, that's as hard as we should push. If you look at the statistics of all the heart attacks that have come into a hospital, 75% had normal cholesterol LDLs, 75%. And normal is 130 or less. The peak of that bell-shaped curve is right sitting on 100. Most heart attacks are happening at 100 LDL. So how do you like that recommendation now? It's terrible. Another one, blood pressure. National recommendation is don't treat it unless it's over 140 over 90. So if you look at national committees like JNC, Joint National Conference on Hypertension, they track data on high blood pressure and the outcome of a high blood pressure, like a stroke and a heart attack specifically. At 140 over 90, you're at 3.5 times higher rate of dying from a heart attack and a stroke, and the national recommendation is to leave you there. Their same data shows your risk of dying from a stroke and heart attack is 3.5 times lower at 115 over 75. And every time you add 20 points to that number, get to 135 over 75. You've doubled your death rate. So next time you see your doctor and your blood pressure is 135 over 80 and you say, it's pretty good, right? No, it's twice as bad as it should be. So again, my point in this is that we don't reach the national recommendations, and the national recommendations are fairly lousy in protecting us. And one of the things that I focus on is getting you to the optimal goals. There are goals that are better than the national recommendation, and they're not my invention. They're well-founded, scientifically proven goals that everyone should reach. And unfortunately, our system can't afford that. That's the honest truth. We cannot afford the cost of getting everyone to those goals. That would require screening, like things beyond mammograms. How do you screen for vascular disease? Well, you should look at the blood vessels, and then you'll know. Many other things. How do you screen for aneurysms? Well, you're not allowed to. Until last year, if you were 65 or older, Medicare now says, we'll cover the cost, a one-time cost, only if you get it within the first 6 months of turning 65. Otherwise, if you miss that window, sorry. We'll let you have an ultrasound of your aorta in the abdomen, but only if you have a family history, but not if you're a woman, because you have to be a man who smoked to be okay within the first 6 months of getting that screening ultrasound. That's true. Hard to believe. It's a simple, quick test, and it can screen for one of the things that kills us without warning. So we need to do a much better job in prevention, and I think that we have noted a national trend toward private practice. True private practice is really, my contract is with you. You know, I agree to treat you, and you agree that you want me to treat you. And we take the encumbrances of the system out, essentially. We put you first. And today, we have cost constraints from government entities. They're looking at their cost sheet. We have healthcare industry, like insurance, private industry, that's looking at their profit side. So when you cut costs, you have to cut care. And people are going to realize, and they're going to wake up in a few years and realize what is going to end up being left over for them. And I'm afraid it's not what you're going to want to see. So private medicine or concierge medicine is a way to remove those barriers, and for people who are really interested in their health and their longevity and their functional status, it's a way to give you all the things that they say you can't have that are not medically necessary. So that's really a focus of my current practice. And there is some new data coming out that will be published this year that a group in Washington State has been doing for 10 years. They've taken, using a different method of actually looking for the vascular disease in the earlier and moderate stages, that 1 in 3 death rate down to 0. They've had 0 heart attacks and 0 strokes in over 600 patients over 10 years. That's pretty impressive. If we applied that to the United States and took 10% of $180 billion for screening, we could afford that. And we would have nursing homes looking for customers, which would be a good thing. So that's a quick summary of what I do. I think the opportunity for improved care is there for patients who are interested and doctors who are interested. I know every physician in this room would like to deliver better care, and I know that he feels he's stuck or she is stuck in a dysfunctional system that doesn't allow us to deliver the care that we want to. So believe me, there's dissatisfaction on both sides, and there are better ways to do it, and it can be affordable. So one of the reasons I think I'm the only one doing this in Manatee County is the fear factor. There are 4 or 5 physicians in Sarasota that have been doing private medicine for about 6 years. They're doing well. The benefit is you get to spend 1 to 2 hours with your patient instead of 10 or 15 minutes. So you're not going to see 3,000 patients a year like I used to. You might only see 200 or 300 a year. And those people get an advantage. My point is, the fear factor is, what if this doesn't work? What about my mortgage? What about my kids' college that I have to pay for? So that fear has, I think, kept it out of Manatee County. I believe there's a need for this. I know this is successful already for me. I know it's going to grow in this county, and I think this is going to spread over time. And I think people will be looking for a better option in the healthcare arena over the next couple of years. And I think that option is available. And I think you will see a split 2-tiers or 3-tier care system, and this will be one of those tiers that survives out of patient request and, interest. Be happy to take questions later. Thanks.
Thank you, Dr. Laurier. Colonel Brochet?
Thank you. Good afternoon, ladies and gentlemen. It's a pleasure for you guys to allow me to stand in the den and to give you some information on what I think is the finest federally qualified health center in the United States. I was going to go ahead and do a lot of overview stuff, but I think really what I want to do is talk to you about what the healthcare system looks like at rural health and how that might affect how health care is delivered in the future. So, that's the first slide. I heard Tom Brokaw say that one day. To make a buck is easy. It's a lot tougher to make a difference. And so I tried to make sure that I impart to the staff that every day we'll make a difference in somebody's lives. And so the other day, Tuesday, I was running to East Manatee and a lady stopped me, and she was all panicky and she was vacillating between hysteria and despair and everything. She said, "Sir, I need to talk to you. They told me I had a mild heart attack on last weekend, and I don't have Plavix, and I don't know what to do." So what I did is I called one of my physicians, I called the chief pharmacist, and we got her Plavix. Before that, we had to take care of the anxiety, get all settled down. We gave everything she needed. Then on yesterday, we had one of our people to sit her down and apply for all those medications through Pfizer's program called Share the Care. So she'll be getting those medications now for free. The taxpayers won't have to have the burden of having to take care of that hospital bill or whatever else that might have accrued out of that particular incident. Next slide, please. That's our mission. Essentially what that says is we want to make sure that we give quality, highest quality health care to anybody in the county or our service area, irrespective of race, creed, color, national origin, so forth. And I think we do a great job at that. And as we move through the slides, I think you'll agree with me. What I want to do is to also say right away that the private physicians in Manatee County, in this community, is the backbone of the healthcare system. What we do at Manatee County Rural Health Services is to become the safety net for those people who can't access those private physicians. And we'll talk a little bit about how that's happening. Dr. Kulu just alluded to it briefly, and we'll talk about it a little bit more. What I'd like for you to do, because I want to engage the audience, because all of you are stakeholders in Manatee County Rural Health Services, even though you might not think so. I want you to kind of close your eyes, and as I go through this presentation, think about what you thought Manatee County Rural Health Services was, what you see it is now, and how you would like to see it in the future. I want to talk to you a little bit about who we are. We're the largest and most diverse federally qualified healthcare center in the southeastern United States. We are a not-for-profit 501c3 healthcare corporation. We have about 77, probably 80 now, medical providers. One point that most people think that is totally untrue is that we depend heavily on federal funding. When I first came to rural health in 1984, our budget was 90% through grants from the federal government and 10% that was generated by us locally. The board asked me what would be my first priority, and I said to flip-flop the funding to get the feds out of our business. So what we've done is we've gotten the feds as low as 7% in our budget in terms of what they give us for grants. With the stimulus money that we just received, it's now up to 12%. Still not bad. Next slide, please. Manatee County Rural Health Services leverages our monies in the community at the rate of 301%. The average across the nation is 150%. Bottom line to that is for every $1 the feds give us, we generate $3 for that $1 for care that is uncompensated. Because the economy is going bad, we're now seeing that to be about 400%, because people can't afford to pay that sliding fee scale, and then we write it off as bad debt. We're in 3 counties. We're the largest provider of health care in DeSoto County for private doctors in the community, probably the largest in Manatee County. We have some health care in Sarasota County. We're Joint Commission credited for 12 years now. We have about 25 health centers and about 17 medical specialties. Those are they. I won't read them for you. Infectious disease. I don't know if you guys had any long-term memory regarding that. There was a time in this community when AIDS, HIV, were having funerals almost every day. The county asked us to come together and decide what the system should look like for AIDS, HIV. We had all the mayors, the county commission, legislative delegation, private physicians, health department. All of the players were involved. I chaired that committee, and afterwards, the county administrator asked me to administer the program. First thing I said was, we don't know what's there. Manatee County Rural Health Services mission is to be a safety net for people who we already know about and their health care problems. We have no idea what it's like for AIDS, HIV. The long and short of that story is the county agreed to underwrite any losses that we had. And I think if you go back in history, you'll find out that we were the only company that ever gave the county money back. Because based upon what we projected it to be, we went out and got other resources. We did it efficiently and effectively, and we actually gave the Board of County Commission money back for running that program. We are the only AIDS HIV facility in the county besides one private physician in the community. Next slide, please. Those are the doctors by specialty. I won't read those to you. The president told me I had about 7 minutes to do this, so 7 to 10, so I think I'll do it in that time. Next slide, please. Those are some interesting data there. The number of patients we have in our system this year, when I say this year, for calendar year 2010, we had roughly 86,000 patients registered at Manatee County Rural Health Services for that 1 year. Patients are at or below poverty level, 54%. Patients by payer type, Medicaid 30%, Medicare 35%. That used to be a real low number. When we got into the skilled nursing facility business, because I happen to have gone through some personal things with my family with nursing homes, and I know some of you have had the same experience, and you go in and you have people who are there for 5, 6 years and nobody goes back to see them. And I think that that's a travesty to what families should be doing. So we've gotten to get involved with that business, make sure people who inappropriately are in those facilities get put back into a lesser facility, hopefully get integrated back to our primary care home facility, then have a medical home, and if it reverses itself, we do the same thing and back again. Big savings to the taxpayers. The breakdown by race, 44% white, 14% black, Hispanic 18%, and unreported people where they don't check at all is 24%. The amount of deliveries in Manatee County that we delivered were, the number there is there, almost 2,000. That represents 2 out of 3 deliveries in Manatee County. We deliver almost all at a high risk because we have a perinatology agreement with the University of South Florida to provide those services. Those are the utilization statistics. Give you a good perspective on how the demand for healthcare is gone in Manatee County. In '05, we had roughly 64,500 patients. And the number of encounters, and encounter is a word that the feds use, it's a visit. But encounter is defined by the feds as one patient at one facility at one day, one 24-hour period. So if a patient went to 5 of our facilities in one day, that's still one encounter. So with that definition, you can see the number of encounters that grew from '05 to 2010. Roughly 407,000. A lot of encounters. Next slide, please. One of the things Dr. Kulo talked about was the study that was commissioned by Manatee County Board of County Commission, was later delegated to the Board of Chamber of Commerce, was conducted by University of South Florida. One of the conclusions that was reached in that report was that the doctors that we have in the community are retiring faster than we have young people to replace them. And so how do we do that? So to that end, what we've done is we've come together, ourselves in the hospital, Manatee Glens and others, and talked about how we do residency programs. The method to that madness is the studies also show that whenever a residence prospective doctor does his residence, he or she normally settles within 50 miles of the place that they did that residence. And so what we've done is we've actually partnered with Manatee Memorial. We've talked to HCA, LECOM, University of South Florida, and others to ensure that, and we're currently doing some of those rotations now with most of those schools, including Southeast Nova. The primary areas will be family practice, pediatrics, geriatrics, and OBGYN. LECOM has also just got a new dental program. They'll probably have somewhere in the neighborhood, I'm told, about 150 chairs. That's a lot. Because the greatest need every year for unmet services in the county is dental services. And that impacts heavily on health care other than dental. Next slide, please. Those are our community partners. I won't read them for you. But those are the people who we work with continuously, day in and day out. One of those relationships I like to really mention specifically, because in most communities, the community health center and the health departments don't necessarily always work well together. Dr. Bensi, thanks very much for being that person. We work tremendously well together. We not only do that at the local level, we try to coordinate our educational pieces to the local legislative delegation and the leadership in the House and the Senate. So thanks again for that. Next slide, please. Those are some of the rest of them. Next slide, please. Manatee Memorial Hospital, ERD. Now, this is a very interesting program. The legislature gave us some temporary funding to do emergency room diversion. In effect, when a person goes into an emergency room, if that person is not a true emergency, then they take care of the stabilization process and then refer them to us for treatment, care and treatment. You'll see the data there. We started out with a small grant in 2005, and you see the increase in the program to 22,000, in excess of that in 2010. Same thing in 2009. So you can see, if you were to go to the next slide, based upon a person going to the emergency room and getting treatment for a nosebleed or headache versus coming to us, from September 2007 to 2010, we saved the taxpayers a little bit more than $18 million. Very effective program. Now let's talk about, next slide. Let's talk about a little bit about what happened yesterday, and I was hoping it wouldn't happen. Our legislative delegation took that funding from temporary to permanent in the Department of Health budget. And so you can see the kind of savings that we generated from that $1.2 million. Yesterday, I'm told that that funding got cut from the Department of Health budget. So I don't know what the governor's thinking is in that regard. I see one of our senior guys, Mr. Governor.
Because I'm not there.
He's the one that works so diligently, and I want to thank you and Ron Reagan and others, Mike Bennett and all the legislative delegation, for seeing the wisdom of that. He even had the Secretary of ARCA to come down and take a look at it. She was totally impressed. And so what we've done is we now got to figure out how we do that without state funding. One of the things we also do is continue to strive to use the best technology. We talked about how the healthcare system is going to look like in the future. Right now, in places like Market City, we can't afford to have a full-time pharmacist out there, so we have a thing called telepharmacy. Real time, the patient sees the doctor on television. We have a technician or the physician who talks to the doctor, the central pharmacist. We have a barcoding system, triple barrier protection. The medication is prepackaged, it drops, and the patient gets that medication. So that's one of the things that we're doing on the cutting edge of technology. Next slide. Electronic medical record, we have a fully integrated practice management system, and it's interlocked with all of our health centers throughout the 3 county areas. With redundancy in the system, in case one goes down, it goes to the other. So those are the value received from having that fully integrated medical record. Next slide, please. Dentistry, greatest need. Estimate that some of the greatest problems are attributed to lack of dental care, which includes ear infections, sinus infections, weak immune system, and heart conditions. We looked at the five top diagnoses in Manatee County. It happens that the hospital, Manatee County Rural Health, and the private doctors see the same thing as talked to by one of the doctors here, congestive heart failure, diabetes, and those things. So what we're doing, and I'm trying to wrap this up real quickly, is that we follow the minimum guidelines, so everybody's kind of looking at those things the same way. If a doctor wants to deviate from that, he has to have a very good reason to. Otherwise, we are all looking at things the same way. Doesn't take away the doctor's judgment as a physician. It simply forces him to do what's necessary in each case to follow the proper procedures for the care and treatment of that patient. Those are some of my successes. And of course, the challenge is the implementation of medical home. We're working with Young Johnson Fleece in that regard, and a legal firm that we use, Blaylock Walters. And we're working with the health department and all the other players in the community. Just talked to Dr. Braxton about it. We're going to be sitting down and talk about how we all work together to make this healthcare system a healthcare system that's responsive to your needs, not to some philosophical needs. Next slide. I want to thank the mayor and the council and the Board of County Commission for assistance in the bond issue. It tremendously reduced our debt service by those refinances. And then finally, we had a creation of a foundation, the Family Health Care Centers of Manatee. And I don't want to tell you who our new recipient is this year, but it's going to be somebody that's going to be fantastic. It's going to be, I think it's going to help to bridge a greater understanding of who we are and how we work with the medical community. And I'm looking forward to making that announcement in the future. That's the new facility that's at 2318, right next to Gateway Bank. That's what it's going to look like when it's done. I did pass out one thing for you, and Pat Glass, I'm looking at you. I know you remember these days. There was a time, the Braden Herald, you can go back to your archives, Dwayne. The Braden Herald did a story where women were standing in line 4 days in the morning trying to see a physician. In that article, one lady walked 6 blocks, or 10 blocks 6 times to try to get an appointment, but we didn't have enough docs. What that article doesn't say is that it got worse. Ratliff from Channel 13 or 8 did another story, follow-up story. The women actually started to stand in line at 4 or 5 o'clock today for an appointment tomorrow. That's third world kind of cure. And so what we've done is brought together a team of obstetricians that we can now proudly say that around 65 to 70% of all those pregnant women get to see an obstetrician within the first trimester of pregnancy. I think that's one heck of an achievement for what a community standard should be. Next slide, please. Dr. Van Buren's office, very quickly, that used to be Dr. Halsell's office. Some of the ceilings are 6.5 feet. So we're going to take that canopy off, raise the liner to would be about 10 feet. The good thing is no supporting walls in there, so we'll be able to redesign it. We have a sick side and well side, and that will be Dr. Van Buren's office. We're dedicated to doing what we're talking about now, 7 days a week, 365 days a year. At the beginning of this presentation, I asked you to shut your eyes and see what you think it should look like. I hope when you get to this question and answer period that you might be able to tell us that. And then I want you to imagine what this community would look like if it were not for Manatee County Rural Health Service being here. I thank you very much for listening, your attention, and whatever questions you have for me, I'll be happy to answer. Thank you.
I can tell we're going to run over, and so if some of you have to leave. Yes, Carol?
Nobody picked up our cards, but I wanted to ask a question.
Well, if you'll bring the card up to me, I'll ask the question.
It was too long, so I just wrote, can I ask a question?
How can I deny a county commissioner?
First of all, I'm Carol Whitmore. I'm a county commissioner. I'm also an RN, a proud nurse since 1977. And I just want you to know, everybody in here knows I'm a friend of medicine in Manatee County, and you all know that. It was very interesting today to hear all the presentations, and I'm married to a surgeon who a few months ago received 1 cent from Aetna for an insurance payment. It cost 44 cents to mail the darn thing. So I can understand the difficulties of medicine nowadays. I have volunteered and worked once a month at the Homeless Coalition in Manatee County. Thank you, Bill Galvano. I've talked my husband into it. He operates once a month on patients that have lost their insurance because of everything or are homeless. Every month we go down there. My question to you, because you all are in business, you all have every right to make all the money you want because you do take good care of our citizens. My question is to you is why is not the medical community stepping up to the plate at the Homeless Coalition? We have the We Care program. But We Care, you agree, you sign a contract and you see 1 patient a month or how many ever you want, which my husband does. But I go to the homeless where they don't fit anywhere. They are on the streets. And it just breaks my heart. And I just think that's a big gap in Manatee County. And I'm imploring to the Medical Society and anybody to please do that. Dr. Jim Rogers just started going. He did his first time a few weeks ago. Dr. Matina goes, and my husband. LECOM are the doctors there, the family practice, and they do very good. But what about the medical community? I really implore you. Thank you.
Very quickly, Carol, you have our commitment. Just give me a call. We'll volunteer some docs and we'll get it done.
Where to start? How does a family member communicate an addiction to an OxyContin problem to a physician who has missed it for years, given the HIPAA law? And I'll let anybody. How does a family member communicate an addiction to OxyContin problem to a physician who has missed it for years, given the HIPAA law?
I'd like to tackle that one. I think people overinterpret and misinterpret HIPAA, and Jonathan Fleece could probably back me up on this. But one of the things that HIPAA allows is the free transmission of information to other care providers if it's about your care and your treatment or operations, how you work your practice, or demographics, your name, your address, your phone number. So if a family member would be with the other family member who has the addiction, and the addicted person says, you may tell my daughter anything about me, then you don't need a signed consent from the addicted person to tell the daughter, you know, your recommendations or to give recommendations. So I think a lot of what we do, when we see a new patient, we'll ask them to sign a release of information that allows us to transfer information to other treating doctors with their permission. And they typically say, fine. Everybody knows now what a HIPAA form is. Now we see this go overboard, that every single piece of information now transmitted seems to be preceded by a fax cover sheet that has their signature on it again. And that's the fear factor. So my response to that would be, I would call the daughter if the patient allowed me to speak to their family, and wouldn't be afraid to give recommendations. I think we need to take the fear out of it and get, you know, to the basic problem that each person may have and deal with it. That wasn't the question.
That's the opposite of the question.
What was the question?
Oh my, I put it back in my pocket.
I think
The
you're,
question was, when you know your family member is addicted, the family member isn't admitting it, the doctor's missing it.
That's
And
not-
you
that's-
feel
That's, it's not a.
you're not violating your son's HIPAA protection by calling that physician. You're a concerned family member. I mean, if that's what you're, okay, if it's the other way around. But either way, I mean, I think what has happened is that people have been so afraid of violating a federal law that it has paralyzed our system. And it's one of the areas of dysfunctionality that has grown out of that law, that was originally to protect people's records.
Dr. Leary, while you're up there, does improved cardiovascular care just kick the can down the road and only delay onset or truly prevent cardiovascular disease? Will people who are older merely have only a more prolonged period of disability at the end of their lives and therefore cost more to society?
Okay, so I'm going to go with absolutely not. One example was the diabetes prevention program that looked at just exercise and diet, no medication. The statistic was something like 58% of patients who would have developed diabetes did not. But if you were over 60, it was like 78%. So the older you are, the more the benefit of prevention. And if you look at a stroke, let's say we'll take stroke in a 45-year-old, it's disabling, and it may or may not take them out of work, but ultimately they tend to recover better. They go through rehab better. They have a better long-term outcome. If you look at an 80-year-old who has a stroke, it is much more devastating, it's much more disabling, and typically may end up placing them in a nursing home. So by avoiding the disastrous consequence of a heart attack or stroke at a later age, your magnitude of benefit is greater by not experiencing that event. It's just like people who used to say, why should I treat high cholesterol in an 80-year-old? And the answer is, they're the ones who receive the greatest magnitude of benefit. That's who you should concentrate on, in addition to everyone else. So yes, it's not kicking the can down the road. You can arrest the disease process now. It's not too late if you've already had bypass surgery and one heart attack. That's called secondary prevention or tertiary prevention if you've actually had an event. I've had one stroke, I really don't want a second one. Tertiary prevention. Secondary, I had a stent but I haven't had a heart attack, but please keep my heart muscle alive. Secondary prevention is very effective.
Thank you.
And it saves money.
Colonel Prochet, please respond to the assertion by many doctors in private practice that Manatee County Rural Health Services cherry-picks patients with some health care resources while giving minimal care to indigents, especially follow-up care.
Okay, well, if anybody wants to come over and take a look at what we do, we'll be happy to give you the $2 tour. In every community, there are misconceptions. There are obviously misinformation. We take care of before we got into the skilled nursing facility business, last year, 41% of our patient base were Medicaid. 41%. 40% was uninsured. That's 81% of patients who could not be seen by other doctors because most doctors don't take Medicaid and they don't take the medically uninsured. Now, that doesn't mean that we don't have doctors out there that still will help us to do those things in the, when they need a specialty care, but we do take care of a lot of patients. So I think there's some misinformation. I'd be happy to clear it up if anybody wants to come over, and we'll talk to them about it and show them.
Thank you. Dr. Clulow. The Florida Medical Association says that poor reimbursement rates in both Medicare and Medicaid is one of the primary reasons physicians are fleeing the state. Can you give us a rough estimate as to what percentage of your practice is Medicare and Medicaid versus private practice? As a percentage, what would you estimate is the amount of free health care you provide every year?
Before I answer that question, I just want to make a comment to Commissioner Whitmore. I didn't know if that was really a question or a statement. She was talking about the homeless, and I just want to comment to that because I'm on the board We Care. And I just want to state that, I think that we have to better communicate to the physicians of this town. I think a lot of physicians would like to donate their time, and some already do, which I'm going to come back to the question that he just asked. But I think the misconception is, or at least a big misconception is, physicians think that if volunteering for that time, they're going to have an issue with liability, and they do not want to take that liability on. I know that that's not true. I personally know that, but I don't think all physicians know that. When you talk to them, that's what they think. And I think we have to be better able to communicate that to them, that the liability is taken away. Regarding free health care, I'm going to just get roundabout to that end question first. When we talk about, I don't know if I could give you an estimate. I can certainly get you, if someone wanted, I get the numbers, because I don't routinely get them, although in some of our board meetings, we go over the amount of care as an organization, which is millions of dollars, really. I have patients when it comes to, that I've seen for years, and especially with this economic downturn, they've lost their insurance, and have no insurance. I don't tell them they have to go find other care. I either reduce my rates or I don't charge them. Unfortunately, the economic reality is, if I was a lawyer, I can do pro bono, or if I was a businessman, I could write it off. As a physician, I can't write that off as a business expense. I still do it, but I mean, that's the bottom line is I can't give free care to everyone, but I'll give it to the patients that I have. I see patients all the time with no insurance, and I won't bill them or I give them reduced rates. And in this community, I can tell you, if you asked any physician, we all do that. I'd see most anyone. And can you repeat, there was a couple extra questions in there, Medicare and Medicaid percentages?
I think it was a question of what percentage of your practice is Medicaid and Medicare patients, and how do the reimbursement rates under those programs probably equate to some extent to free care?
I don't know if it equates to free care. The percentage that we see of Medicare and Medicaid, it's a lower number of Medicaid. It's probably 10%. Medicare, it's probably reaching as close to 60%. And in this county, if people don't realize it, Manatee County has the lowest Medicare reimbursement in Florida. If you were a Medicare patient in this county versus a Medicare patient in, say, Dade County, the physician would be reimbursed at a different rate, and actually a higher rate in Dade. I don't really understand the discrepancy. That's for the legislators of how they determine who gets the money. But I think that we've lost some physicians. I can tell you, in my practice, Dr. Warren Chin, he moved north because of the higher percentage of Medicare patients that he had, which meant lower reimbursements for him, and then that meant having to pay his staff, and he couldn't do it. He ended up moving to New Hampshire, where he had a higher percentage of private pay insurers. So that in that aspect paid him better, I guess, than here. So.
Thank you. Dr. Laurier, Can you discuss the costs associated with concierge medical service?
I don't know if you want my specific fees or not, and I can ask you your specific fees, or I'll give you a general overview.
It's a general question.
Okay. Fair enough. I'd like to also just give a general answer to the last question you asked Dr. Clulo, and I'll segue it into this answer. I think the average physician in this county sees about 75 to 80% of his practice as Medicare. Anybody disagree with that? That's a physician? It's about 75 to 80%. The reality is also that because I've been a solo practitioner for a number of years, I am the guy who looks at, reads, and signs the contracts. Private insurance is about 105 to, at max, 110% of the payment rate of Medicare. It is not a lot more than that. So as Medicare sets rates, they all ratchet down. So it isn't, it's that the Medicare reimbursements for certain procedures or visits has now approached or become lower than the actual overhead of delivering that service. That's what's forcing physicians out. The answer to your question is setting a fee for a patient that is going to pay me out of their own pocket really depends on the services that you offer, and I actually have 2 programs. I'd be happy to talk to anybody about it after this if they want, and I'll give you the exact number. I also looked at geographic examples. I am significantly lower in price than the Sarasota docs, who are probably lower than Naples, San Francisco, Chicago, wherever. So I think there's some geographic pricing of that. I think so part of it is what are you offering, and is it something that gives them a good bang for their buck? And one of the things that I focus on because of prevention being a big part of what I do, I try to re-educate people that, you know, they say, well, I can't afford that, or my neighbor couldn't afford that, but I can. I don't think that's fair. And the answer is sometimes you need to look at your life and your health as your biggest asset, and you can't afford not to take care of yourself because a government program or a county program or an insurance program really doesn't have your best interest in mind. They have their financial interests first and your interest second. So people who want their interests to be first are sometimes willing to pay for it.
If I, just as, not asking you to be specific, but is it a lump sum payment? You said
I think
two
that
levels
varies
are-
also. My program is you can have an annual fee or you can break that up into monthly.
Okay, thank you,
And that's flexible and per patient.
thank you. Colonel Prochet. Chronic diseases cost health care approximately 70%. What is Manatee County Rural Health Services doing to help reduce chronic disease?
I talked a little bit about it during my presentation about the minimum protocols. What our docs have done is come together with all of the departments and adopted these standards as means to make sure that they look at chronic diseases in the same way. And the other piece is to have what we call pop-ups in those minimum protocols to remind the doc at a certain point he needs to do X. And so you catch them early in the stage before it becomes an example that Dr. Kulo gave of the house burning down at 90%. So with the earlier the detection, the better the treatment, the better outcomes.
Thank you. This is probably open to whoever would like to answer it. Publix is turning away 30 to 40% of new hires because they cannot pass a drug test, and the primary problem is OxyContin. There needs to be more monitoring of patients on this medicine. How do you do it?
I think the real answer is that there are a lot of pain management clinics that are cropped up in recent times, and there's not a lot of regulation. And so when the police department or law enforcement find out about them and start to do the things necessary, they pick up and leave and go to someplace else and do the same thing. And so until we can get some teeth into the enforcement piece and hold those guys accountable, I think we're going to have the problem. If it's not OxyContin, it'll be something else. And we've seen that happen. OxyContin Condon is the drug of choice now, but before, they did something else. They changed one pill for another. The main thing is for our own doctors to be responsible and don't give a patient what he asked for, give him what they think he needs. One of the things that's happening in this country right now is with deregulation in pharmaceuticals, the pharmaceutical companies are sometimes driving what patients ask for. If you have something like dysfunction for your sexual behavior or whatever, a guy looks at it on TV, he says, well, I'm going to go out and ask my doctor for that. The doctor's not really the guy who's looking at it and saying that. He goes and says, here's what problem I'm having. And so it's a little bit complicated in terms of how it works. But I think the biggest thing is for us to be responsible and give the patient what we think he should have by medical judgment, not what the patient asks for.
I just wanted to make a comment as well. I don't treat chronic pain patients. Usually, as a family practitioner, if I think that they're going to need chronically pain medication, we're going to send them to pain management. But the issue is people do have pain, you have to treat the pain. The part of the problem is we have reduced regulation, which Mickey had mentioned, and no oversight. And patients, unfortunately, are very manipulative, and you have to be almost like an investigator. I mean, I can tell even in my practice, which we give pain medication out when they're in acute pain, but you know what? If you can't monitor, I mean, I'll have, for example, I had a patient who we gave a script for just hydrocodone, and the pharmacy called and said that, well, did you know that they had a prescription from another patient or from another physician filled on, a week before for a certain number of pills? And then you find out, when you start investigating, you find out that they've had gone to this doctor, to that doctor, to this doctor, and there's no communication. And that's one of the reasons for that bill that there was an issue with Governor Scott with watching those prescriptions. And so I think that if we had better oversight on where those prescriptions are going and who's writing them, because we don't always talk, and it goes back to information technology. If we're able to integrate all those systems, you'd be knowing who is getting prescriptions, where, when, how many, and if the patient has a problem with the drug, you can address it with them and get them help. Versus those people, now there's two people who are getting drugs, because you got those ones who are abusing it, and then there's ones that are getting it and selling it, and that's where you have to try and determine where they are and get those ones help, and the other ones who are selling it off the street. And you can't do it without regulation, oversight, and communication within the community, whether that's through IT or this plan that I don't know what's going to happen to that bill in the state, but that needs to be addressed because people are dying from these drugs. So, but they're not bad if they're used appropriately. The problem is people abuse them.
Not wanting to get political, but you raised the governor's position relative to the drug monitoring program that's supposed to go into operation. Does it make any sense to do away with the proposed program, or will that proposed program, as you understand it, have some positive impact on the problem you're talking about?
I think that it would have a positive impact on the problem, but, I'm not in charge of signing a bill to say it get through.
Okay, thank you. Colonel Prochet, you have refused to let the press attend your board meeting, citing the discussion of patient-sensitive information at each meeting. Given the fact that an expert in community health centers such as yours was quoted in the Braden and Herald as saying that patient-sensitive information would rarely need to be discussed at a board meeting, and given the fact that you receive taxpayer monies from the federal, state, and county governments, how can you justify continuing to prevent the press from attending your board meetings and reporting to the public?
Well, the first thing is, I think the thing about sensitive discussions was really the last thing I gave. I probably gave 10 reasons why it shouldn't be. Sensitive personnel issues, the strategic vision and that we have, a lot of reasons. But the main reason is the word private. We are a private not-for-profit, and therefore we are the same as any other any other business. The only difference is tax consequences. I run rural health the same way as any other company run. Hopefully I run it better. But there's no reason for me to allow the press or anybody else to come in to a private board meeting. It's not my decision, it's the board's decision. But can you imagine having a board meeting with volunteer people, spending their time taking care of business, with people coming in wanting to address the board on any kind of situation that they think is important? So that's essentially the reason. The reason that was given in the paper was probably the last on the list, and it was taken out of context.
Thank you. Dr. Laurier, for years, the trend in healthcare has been to encourage specialists, including cardiologists, to perform outpatient procedures and testing in their offices. Now the trend seems to be reversing, and more outpatient medical procedures are going back to the hospitals. Is this true, and why?
I think that trend is definitely true, and that gets back to the business side of any medical practice. I can speak to my specialty, which is cardiology. In the last 2 to 3 years, certainly in the beginning of 2009 and 2010, and in counties like Manatee, where we may have 70, 75, 80% of our practices controlled by fee schedules handed to us by Medicare, our specialty saw a massive cut in 1 to 2 years, about 40%. So if you're a business that runs extremely efficiently at 50% overhead, and most doctors' offices do not do that well, they're more like 60 or even 70, and somebody takes 40% of your gross away, you're left with 100% overhead. So there are certain procedures, expensive ones, whether it be PET scans, nuclear stress tests, CAT scans, office-based surgical procedures, where the overhead is very close to the revenue, and when that becomes upside down and it costs more, you have no choice, unless you want to go bankrupt soon, but to stop. Now, unfortunately for the consumer and the patient, what they don't realize is the Medicare fee schedule for a hospital is 2 to sometimes 3 times higher for that exact same test or procedure as an outpatient, and therefore your copay is 2 to 3 times higher. So yes, it's more convenient if you can go to one place. They already have your driver's license, your insurance card, your allergies, your medicines, all that jazz. You don't have to come in, wear an armband, and get an IV and wait for 2 hours. But the efficiency is actually going to go the other way. We are going back to the hospital because it is unaffordable for physicians to do some of these tests and procedures in the office. So that is driven by financial concerns, not convenience or the physician's desire to jettison that benefit or that procedure. That is what's happening, and that will continue to happen.
Thank you. Thank you. With the state proposing to cut funding for the county health departments for primary care, who will provide the care for these individuals? Anybody?
I think the answer is in what we talked about earlier, where we all get together and talk about what the healthcare model is going to look like at the end game. We all know that there's not going to be any more money. The question is how we work together and seeing how that money is shared in the whole consortium of healthcare. And so when the health department doesn't have that money, then we have to work together more closely. And I think those kind of discussions have already begun in Manatee County. I think somebody like Jonathan Fleece and others, Dr. Rogers, and a lot of other people in this room. But I believe that we're going to be able to take care of those patients. It's going to be a little bit more difficult. But what we're finding in looking at the technology too and treating patients better, there's no inverse curve between quality of care and cost. You actually get lower costs as you increase quality. And so that's what we have to work toward in that model.
Thank you. We are well beyond our time. I'd like to thank our 3 panelists, for their presentations and their willingness to answer questions. I think they all deserve a hand for coming out and educating us. Thank you so much. Thank you.